Good afternoon to everyone. I'm Piotr. I'm from Maribor, Slovenia, and today we are continuing with our Young ESPGHAN Webinar Series. Today we will be talking about Wilson's disease, and we have our speaker, Professor Dr. Piotr Socha. But before we start with the webinar, I will just do a short introduction of the Young ESPGHAN. You know, the Young ESPGHAN Committee, our mission is to promote the research of the young members. We organize different activities. Also, we represent the interests of young members inside the ESPGHAN society. Here's a picture of our committee. We are also very active. Here you can see the members, the chair Anne-Marie Grima, the secretary Vangeli Jamuris, and here are the other members and also our roles in the scope of our committee. We have many activities. Among them is also Young ESPGHAN Mentorship Program, which is starting next week with the online mentorship workshop. Last year we have 12 pairs of mentors and mentees who met in Helsinki for the first time, and this year we have 10 pairs who will meet for the first time in Lille at the end of June at our annual meeting. We organize different educational events. Last year at the annual meeting, we had also Young ESPGHAN Day when we were talking about systematic reviews, about reviewer program, and we finished the day with a Young ESPGHAN session on immersive painting. And here you can see some results of our session. We really had a very nice time. There, we also organize every year Meet the President session during the annual meeting. Last year, we met the past president and the new president of ESPGHAN. And what is new? Last year, we had a new Young ESPGHAN session about navigating clinical cases from young professionals, which was also very successful. So I invite you also to join us this year at the annual meeting. If you want to join any courses, you can find all the information on the ESPGHAN website. You click on the courses and you can see the upcoming courses for this spring and summer. And if you are not yet a member, you can also join us. You can find all the information on the ESPGHAN website on also how to apply to become a member. We also have an ESPGHAN app when you can find all the information. And if you want to follow Young ESPGHAN, you can also follow us in the social media. And before we start with today's webinar, I would just like to invite you to the next webinar in June when we will be talking about the low FODMAP diet. But today, as I said before, we are focusing on the Wilson's disease. And I would like to welcome today Professor Piotr Socha, who is the professor of pediatrics and gastroenterology in the Department of Gastroenterology, Hepatology, Nutritional Disorders and Pediatrics, and the deputy director of research in the Children's Memorial Health Institute in Warsaw, Poland, which is the referral pediatric hospital for Poland. His research and clinical work were mainly devoted to cholestatic liver disease, non-alcoholic fatty liver disease, rare metabolic liver diseases, nutrition and in hepatology and gastroenterology, obesity prevention and therapy, feeding disorders, protracted diarrhea, and inflammatory bowel disease of infancy and early childhood. Professor Piotr Socha was the chair of ESPGHAN Hepatology Committee, the scientific secretary of ESPGHAN, and since last year he is also ESPGHAN treasurer. He contributed to 9 European Union projects with leading positions. He was also the president of Polish Society for Pediatric Gastroenterology, Hepatology and Nutrition, and he published around 500 peer-reviewed papers and contributed to 40 book chapters. Among many others, he was also leading ESPGHAN and EASL Wilson's disease guideline group, and we are therefore very honored that he is here with us today to talk about Wilson's disease, about diagnostics, about the therapy. And so, Professor Piotr Socha, thank you very much, and the floor is yours.
Thank you for the nice introduction. And this webinar is extremely important for me because I'm invited by young doctors. And at the end, I expect difficult questions because the most difficult questions come usually from young doctors. I will just share my presentation in a minute. Hopefully it will work. Is it fine?
Yeah.
Do you see the presentation? So the topic is Wilson disease. And in fact, I will refer to ESPGHAN guidelines 2018 and the recent from the last year guidelines EASL and ERN. And I think we will discuss guidelines, but I would also like to show you two cases just to discuss practical problems topics, because reading guidelines is not just the solution for solving problems. So solving problems, it is something which we will focus on during this 45 minutes. These are my disclosures. And I will start from the very basic things that hepatic copper metabolism is primarily located in the liver. And as you probably know, ATP7B, this protein, is responsible for uptake of copper from cytoplasm of the liver cell into the Golgi apparatus. And the only way to excrete copper, in fact, is the transportation to the bile. So if this is impaired, copper will accumulate. And this happens in Wilson disease. So ATP7B doesn't work properly, and copper accumulates in the cytoplasm, but also ceruloplasmin is not produced in big amounts because there is no copper to be bound with ceruloplasmin. So ceruloplasmin level goes down. And this is what we usually observe in Wilson disease. And now let's go back to the guidelines. Why it is important to refer to the guidelines? Because guidelines were really prepared according to the very sophisticated, methodology and very demanding methodology. It was really hard work for 2 years. It was, I would say, my second job for these 2 years. First, according to EASL guidelines, CPG panel was chosen from the experts in Europe. And this CPG panel was responsible for defining so-called PICO questions, and finally, of course, for literature review and formulating recommendations. But next to the CPG panel, we also had the support of the Delphi panel group. This was a bigger group of experts, 35 experts, who first reviewed the PICO questions and finally also reviewed the recommendations. So we had 24 PICO questions, many recommendations, and this was really hard work. But finally, we reviewed whole literature on Wilson disease, and I think we know the gaps, we know the strengths of what can be really found in literature, but we also know the gaps, and I will also critically comment to the recommendations which I would like to share with you. But before we started with recommendations, we also tried to describe the clinical presentation of Wilson disease and differential diagnosis. And as you remember, and it's also written in the book, so I will not spend too much time on that, symptoms can come from the liver, from the neurological tract, from central nervous system. Some patients may have psychiatric problems, and other organ manifestations are rare. But what is really the most important, it's the hepatic manifestation, which is not easy to differentiate from other liver diseases. And I listed here some most important liver diseases which can really look very like Wilson disease. What is important, Wilson disease can be any liver disease, really any liver disease, in a child above 1 year of age. So it's not easy to make this differential diagnosis. And just to give you a kind of a comment on differential diagnosis, you know that these patients with Wilson disease and other liver disease may present with hepatomegaly, splenomegaly, increased ALT, AST, or severe symptoms, or may have acute liver failure. So these symptoms are really not enough characteristic to say that it could be Wilson disease or it could be autoimmune hepatitis or another disease. So these are common clinical features. There are common laboratory features which really do not allow to make a decision which kind of disease it could be. So finally, copper abnormalities, copper parameters can be really important to make the final diagnosis. But some tests can be misleading, and we, in the guidelines, but also in some other papers, we tried to draw your attention, I mean the practitioners, that autoimmune hepatitis can be confused with Wilson disease. It happens quite often. There are quite many case reports showing this confusion and false diagnosis of autoimmune hepatitis in Wilsonian patients. Why is that? We analyze autoantibodies and other tests which are measured for autoimmune hepatitis in consecutive patients with Wilson disease. So 74, now we have in our database 250, so really a big experience from our center. And most of these patients presented with positive autoantibodies, mainly antinuclear antibodies. Never we found anti-LKM antibodies. So we can say anti-LKM antibodies are really very specific for autoimmune hepatitis, but others are not. So be careful. I would say that about 10 patients in our cohort had primary diagnosis of autoimmune hepatitis, which changed later to Wilson disease. Again, there are some new rare disorders which look very like Wilson disease, and one of the recent described by our group. So it started from our patient, Polish patient, and then in Nijmegen, colleagues from Nijmegen started a new big grant, which finally led to discovery of a new disease in VMA21 protein, which is a kind of glycosylation disorder. So on the right side of this slide, you can see electrofocusing of transferrin and this hypoglycosylation. So the patient number one is our patient, is our case, it's our new disease, a new VI-ATPase deficiency disease, which presents as a glycosylation defect with steatotic liver disease. So it's a new disease presenting as liver steatosis with some abnormalities of lipid metabolism with high cholesterol. And that's why I presented to you, because perhaps in the near future, we'll also discover new and new diseases. And sometimes you think it should be Wilson, but if you cannot confirm Wilson, consider that it can be also one of not discovered diseases, and we have to dig further. But coming back to Wilson, this cartoon, I think, is one of the most important in our guidelines because it puts together the diagnostic approach. And there are some changes compared to previous recommendations. First of all, as usual, we start with suspicion of Wilson disease. So awareness of Wilson disease is most important. Then at least 2 liver copper tests should be done, copper metabolism tests should be done. This is serum ceruloplasmin and 24 urinary copper excretion. Not one of them, but 2 of them together, because one of them is not sensitive enough. And then we looked for extrahepatic features of Wilson disease. I will come back to Leipzig score later, but you are aware of this Leipzig score, the scoring system of different clinical and laboratory features. And if you have Leipzig score 4 or more, then you make diagnosis of Wilson disease and start therapy. But if Leipzig score is 1 to 3, still you cannot be sure that it is Wilson. And here we can use another indicator of copper metabolism, of disturbed copper metabolism, which is relative exchangeable copper. I will comment on this parameter later. This parameter was really thoroughly investigated in France for a long time, and it looks like the values above 5 or from 15% and more are really typical for Wilson disease, and we put this parameter as an additional one, if available, to make decision on therapy. Later, molecular testing should follow, and even if Leipzig score allows you to make diagnosis, we really insist that molecular testing should be performed to confirm. If again, with molecular testing, you cannot confirm, and REC and other tests, you cannot confirm Wilson disease, then liver copper can be a useful parameter, and I will comment on liver copper later. But liver copper appears here somewhere at the end of this diagnostic approach. And these are, in short, the recommendations which we put into the guidelines. So what should be the first step, what should be used to confirm diagnosis, and that genetic testing should follow. Just as a comment which appeared also in the text of our guidelines, I have to stress how important it is to use proper cutoff values. Many patients, at least in our practice, our Polish practice, were not diagnosed as Wilsonian patients because people used the laboratory cutoff values. Usually the cutoff value for normal urinary copper excretion is 80. But we indicated here that the normal values are up to 40 in children. 40 to 80 is already abnormal value for which we give 1 point in Leipzig score, and above 80 we give 2 points. For adults, these cutoff values are a little bit higher. So again, be careful with reading the cutoff values, and the laboratory cutoff values can be misleading. Don't use them. Use the cutoff values from the guidelines. This is the Leipzig diagnostic score, and you know from books, so it's not new. The most important thing is just to read it properly and really to combine clinical evaluation with laboratory testing. This diagnostic score was validated only in pediatric cohorts, in Italian by Nicastro and in British cohorts. So there are only 2 publications which show validation of this score with very high positive and negative predictive values. So it's really very, very accurate. But it has never been, unfortunately, never validated in adults. And I can share with you comments from our last meeting in Aarhus. Every 2 years, it means Wilsonian people, experts, meet in this one place to discuss about novelties in Wilson disease for 3 days. And we agreed that perhaps we need a better or a diagnostic score, which will be not a priori agreed score, but we need to elaborate perhaps a better score. But at the moment, we do not have better tools. Still, as promised, I would like to comment on the REC, on relative exchangeable copper, which is an indicator of copper metabolism, of free copper, in fact, of free copper. Free copper is not free in the blood, it's bound with albumin. So exchangeable copper is a fraction, labile fraction of copper, which is complex to albumin. And for diagnostic purposes, we do not use exchangeable copper, but we use a proportion of exchangeable copper to total copper. So this proportion has a diagnostic value as validated in this big group of Wilsonian patients in France, more than 200, and compared to many other liver diseases. So it really was properly validated, and you see sensitivity and specificity, very high specificity, almost 100%. So I believe it is really a very good tool, and it's now introduced in many countries, in Denmark, in Germany, but it's not easy to be performed. Honestly speaking, it's not easy for the laboratories to start this method. That's why it's not so commonly used everywhere. Liver copper, as I mentioned earlier, liver copper appears usually as the last test, just in the situation where we really cannot confirm or exclude Wilson disease. And it was validated in adult cohorts. First, famous Peter Ferenczi proposed this parameter, and the cutoff value of 250 micrograms per gram of liver tissue as a cutoff value. But in his cohort, there were no cholestatic children in the comparison group. So the Chinese paper, the next one, used already also patients with cholestasis. And it occurred in this paper, which is very interesting, that cholestatic patients or those with PSC or PBC may present with increased hepatic copper. So that's why sometimes Wilson can be confused with these diseases. But usually PSC and PBC have other significant features which allow to make this diagnosis. In children, there are only 2 publications in relatively small cohorts by Nicastro in 30 patients, Caesar in 35 patients. I share with you now also our experience here on the bottom of the right side of the slide This paper is under review at the moment, so I hope it will be published in 121 patients compared to a big group of almost 500 patients with other liver diseases. We showed very high accuracy of liver copper with around the curve of 0.99, but we propose to push a little bit to move the cutoff value higher to about 300. That's the only difference. But in fact, it seems to be very, very useful in the diagnostic approach. Finally, of course, mutation analysis is important, and as I commented, NGS should be performed even if the diagnosis is confirmed by other tests. In well-defined cohorts, usually 95% of the patients have really diagnosis confirmed by NGS. There are several limitations, however. We can have some defects in adjacent intron exon junctions, so we can miss it by NGS. Perhaps whole genome sequencing will solve these problems. And variants of unknown significance are also a problem. Sometimes we get report that it is a variant. We don't know whether it's pathogenic or not. And we ask our genetician to help us. There are about 800 variants which are pathogenic and about almost 2,000 which pathogenicity has not been proven. And this is also our experience with these difficulties to make diagnosis based on NGS. Sometimes NGS and perhaps new methods are a little bit better, but in the past, NGS was not able to indicate small deletions. So we had such a family who looked like Wilsonian patients, but we could not confirm it. And with German colleagues, with Hartmut Schmidt, who collected a big group of Wilsonian patients from all around the world, we looked for small deletions with another method with MLPA. So there are other methods to look for deletions, and it is just a comment that you can use also these methods in these difficult cases. So small deletions can also be responsible for part of Wilsonian patients. Finally, there are different methods to test functionality of ATP7B mutants, like different cell models. I don't want to go into details. Still, it's research. It's not for clinical use. We develop such models that from urine, from squamous cells, from urine, you can culture these cells, then transfer them into pluripotential cells, and finally into hepatocytes. And we hope that we will be able to test the functionality of these hepatocytes from urine cells, just not to perform liver biopsy. So there are different methods really to try to check functionality of the mutations, but still not well established for clinical use at least. And just to show you some difficulties, just to share with you our difficulties, in fact, I would like to show you a first case, which was a 5-year-old girl. You see on the left side the basic test. So there was normal liver and spleen size, normal INR, bilirubin normal, ALT increased, AST increased. And finally, really most of our patients with different liver diseases are referred because of increased ALT or AST. So this was the cholesterol was also high. Additional tests were performed, and because antinuclear antibodies were high, anti-alkyl were negative, but antinuclear antibodies were high. Ceruloplasmin was normal. Urinary copper excretion was 50 micrograms per day. That time was regarded to be normal. I would say now it's slightly increased. So the concept, the idea was that it is perhaps autoimmune hepatitis. That's why liver biopsy was performed, which showed portal fibrosis, and surprisingly, micro and macrovesicular steatosis, which is of course not typical for autoimmune hepatitis, with periportal inflammation. So that time, even it was a young child, 5 years old, autoimmune hepatitis was diagnosed, and there was a decision to start steroid therapy with prednisone. ALT at treatment start was increased, significantly increased, and went down during a year to almost normal levels. and prednisone was tapered to low dose. So it looked like it was autoimmune hepatitis, properly treated, efficiently treated. So no further questions. Is that right, or you would still consider that it's another disease? I cannot see your voices, how to say, because unfortunately I cannot see even my face here. We can see on the slides, but just think about it, what this could be, and we will try in a minute to solve the problem. So whether you should still consider Wilson, another metabolic disease, we discussed many of them, and perhaps all the answers are more or less good, not wrong. But in fact, we, and people know me in the department, that I always ask about Wilson, whether it was properly excluded when we have such meeting and we discuss histopathological findings, so we discuss it again and again. So I advised repeat testing, and at the repeated testing, ceruloplasmin was already decreased. Liver copper was highly increased. Liver copper was finally measured from this child, and molecular analysis showed both mutations, HQ, so these very common mutations, at least in the Polish population, but not only. So we had diagnosis of Wilson disease. We started D-penicillamine therapy. Prednisone was stopped. When prednisone was stopped, AT for some time increased. So that's why prednisone was reintroduced, slowly tapered to 5 milligram, and now was completely stopped, and the child is doing well. So it was Wilson. It was not a comorbidity of autoimmune hepatitis and Wilson, because some people say, why not to have the two diseases? From our practice, it's always only Wilson. Finally, we can discontinue completely steroids, and we treat with only anti-copper drugs. So it was only Wilson. That was, I would say, easier part of making diagnosis in Wilson disease, because it was a chronic liver disease, what we discussed. But acute liver failure is really a big challenge. It is a major challenge because we have hours or days to make the diagnosis. So these are our recommendations, easy recommendations, what to do in acute liver failure. Perhaps screening for Wilson should be performed in all adults. It's clear, and children above 4 years of age, so even young children. Now you should look for Coombs negative hemolysis, Kaiser-Fleischer ring, neurological symptoms, so anything which can indicate that it's Wilson. Relative exchangeable copper could help if it is available. And brain MRI may be performed to support diagnosis. We look for changes in brain MRI. Sometimes, without neurological symptoms, some brain MRI changes may occur. We had such cases. And genetic ATP7B analysis should be performed, but usually we wait long. So it should be done, but finally, usually it does not help to make the decision. What is the major problem in making diagnosis in acute liver failure? There's a limited value of diagnostic tests, because ceruloplasmin may increase due to inflammation in Wilson disease to normal levels, or it can be lowered in other disease because it's produced in the liver. So in acute liver failure, production goes down. 24 urinary copper excretion is difficult to perform, first of all, in such acute situation, and can be influenced by cholestasis, so can be increased in other cholestatic disorders. Genetic testing may be delayed, and Kaiser-Fleischer ring is rare. So REC is really a new option, and I show you a publication which was published after our guidance, but sometimes supports our recommendation that in 33 patients, 11 with Wilson and 22 without Wilson, this test appears to be really very sensitive and specific, but it's a very small cohort. These are first results in acute liver failure, so I think still we cannot say that it's so accurate, but really I think this kind of test can be supportive to make a diagnosis in acute liver failure. So finally, we have to start therapy, and it's not easy. copper accumulates mainly in the liver, but also elsewhere in the brain. So we want to avoid neurological symptoms and so on. So we have to start therapy quickly and efficiently. And I would like briefly to discuss with you the pharmacological approach. So we ask the question, which pharmacological treatment is recommended? And of course, the primary choice in significant liver fibrosis, in significant liver disease, should be chelators. So both D-penicillamine or trientine. For the purpose of this recommendation, we use kind of a new term, significant liver disease, significant fibrosis and cirrhosis, because the terms used in literature are not very conclusive. What does it mean, symptomatic or asymptomatic liver disease? Is symptomatic increased ALT or not? So that's why, to avoid confusion, we use this term significant fibrosis and cirrhosis. So in this situation, chelators are primary choice. Otherwise, zinc can be also used as a primary choice also in the neurological presentation. And there's a general recommendation: start low, go slow. So increase mainly D-pen, but also trientine doses slowly, usually even over months, to the full dose, because paradoxical neurological worsening may happen. And in asymptomatic patients, you can use zinc or chelators. This is a table showing different drugs which can be used. D-pen, trientine, I indicated here on one, for tetrachloride trientine, which we use in Poland and in many European countries, but there is also the same, I would say, potency, dichloride trientine, different tablets, a little bit different dosing, and zinc sulfate or acetate. We use in Poland zinc sulfate commonly because it's simply cheap, very cheap. But both drugs are registered. So this is the dosing, and a few comments about side effects. First of all, zinc. Zinc seems to be very safe. That's why usually it's preferable, but it can cause abdominal pain. And in our paper here, for the first time, we describe also in 7 patients gastritis, so ulcerations in the duodenum or in the stomach. In those patients, in selected patients with significant abdominal pain. So it's not so safe, and patients sometimes stop taking drugs, mainly children, teenagers, because of the pain. Yeah, we have to remember that. So zinc is safe, but can cause really significant abdominal pain, and then we have to choose to change to another zinc, from zinc sulfate to zinc acetate, because this gastritis occurred with zinc sulfate only in our experience, at least. So these are the few comments to pharmacotherapy. So that there were some randomized trials, and mainly the most important trial, chelate trial, comparing D-penicillamine with trientine, is very valuable, showing that non-inferiority of trientine compared to D-penicillamine. Slightly different side effects, seems to be a little bit safer. Trientine seems to be a little bit safer, but the same efficacy. So, and some comments to D-penicillamine limitations. Mainly worsening of neurological symptoms is a major problem. Some older patients, in fact not children usually, can have cutis laxa, skin changes, which can be really troublesome. What about follow-up therapy? Once we achieve success, we can change treatment. Either we can decrease the dose of a chelator or change treatment to zinc. It's possible, but we do not advise to change to zinc. We stated that it can be considered for safety reasons, but there is no obligation to change from one therapy to the other. In those who do not achieve treatment response, despite good adherence, and the main cause of poor effect of therapy is non-adherence, and we have to remember that. So first we check adherence. or those who develop side effects, we can switch treatment from DPEN to trientine and vice versa, or from zinc to chelators. So we have several options of changing therapy. In patients with Wilson disease who develop paradoxical neurological worsening, we can decrease the chelator dose, we can slower dose escalation, or change to another preparation, chelators to zinc, zinc to chelators. So this is the advice we give or recommendation we give in the guidelines. I would like to comment briefly on very young children. We published on a group of 21 children who presented with some abnormalities below 5 years of age. And you can see still ceruloplasmin was relatively a good test in this group. Urinary copper was difficult to perform and was not, urinary copper excretion was not very high in these children. Still, most of them were treated with zinc, so very efficiently. Only 6 patients received penicillamine, also with a good effect. Here on the right side, you see the updated our cohort to 33 children with this presentation below 5 years. And what I wanted to show you mainly is that most of them presented with increased transaminases, that ceruloplasmin was decreased in more than 80%, in urinary copper also was increased above 40 in more than 80% of these patients. So still this basic test to make diagnosis valid for young children. Again, monitoring of patients on chelators and on zinc. We commented on that in the guidelines. What is the major problem? What is the gap in literature? This monitoring test, which is mainly urinary copper excretion, were not properly tested versus efficiency of therapy, effects of therapy. So this is more or less a priori values, but we agreed with these values. So we agreed that 24 urinary copper excretion should be between 200 and 500 on maintenance therapy with chelators. Perhaps a little bit less with trientine, because now we know that trientine has two effects of action. One is chelating, and the other one is decreasing absorption from the gut. So that's why we expect slightly lower excretion values in the urine of copper under trientine. Under zinc salts, we expect lower values because zinc action is mainly to inhibit absorption from the gut. So it lies between 30 and 75 micrograms. It's not only about copper parameters. Of course, we should evaluate treatment response based on clinical parameters, laboratory parameters of the liver function and brain MRI. So clinical parameters are liver, ascites, jaundice, neurological, UWRS scale, which is developed for these patients by Anna Członkowska and co-workers, and further by other co-workers from other countries. And laboratory parameters, so we expect that INR and TST will go to normal. Will go to normal, but slowly. Usually in acute liver failure, INR will not correct within 1 or 2 or 3 weeks. Usually it takes really months to correct completely. And we see some improvement after 2, 3, 4 weeks, not earlier. That's why really the expected effects are not quick. We have to be patient. We can use also other markers of liver damage, non-invasive markers, and I share with you our experience. We prepared for publications. I shared with you at the moment from 137 liver biopsies. We evaluated ALT/AST platelets as indicators of fibrosis, and again also FIB4 and APRI. And FIB4 and APRI seem to be relatively good with around the curve for significant fibrosis, also 0.75. So it looks like really this test can be useful, but they are not very, very accurate. Again, what should be done with a patient with acute liver failure once we suspect Wilson disease? First of all, our recommendation is to refer this patient to a liver transplant center. because we will not have much time to make decisions about therapy or liver transplantation. So first of all, send to a liver transplant center. Then if the patient has encephalopathy, the chance to survive without liver transplantation is almost zero. So should be immediately listed for liver transplantation. If there is no encephalopathy, we evaluate these patients according to King's College prognostic score, and scoring 11 or more, I will just comment in a minute, gives very little chance to survive, so the patient should be listed for liver transplantation. Even if the patient is listed, pharmacotherapy with chelators should be started. Some patients were rescued from liver transplantation with chelators, so chelators should be started even if we make a decision on listing for liver transplantation. High volume plasma exchange is regarded now a good method for bridging for liver transplantation, and I will also show you some data from India. Many of them were rescued from liver transplantation when survived only with high volume plasma exchange. We still discuss what are the reasons for these good results in India, but we think it should be taken into account anyway. So this is the King's College prognostic index in acute liver failure. We score bilirubin, INR, ST, white blood cells, and albumins. On the left side, you see the group of patients which was evaluated at King's College with children, not only with typically acute liver failure, some of them had acute and chronic liver disease, apparently exacerbation of chronic liver disease. As you can see, ceruloplasmin was a relatively good indicator of Wilson disease in this cohort. And again, index 11 or more means poor prognosis. So this is the prognostic index, very sensitive and very specific in evaluation at King's College. This is the experience from India where they compared two groups. These groups were not randomized. That's the major problem with this study. And some of these patients received high volume plasma exchange, the others didn't. And liver transplantation is not easy to be performed in India. That's why many of them died. But as you can see, the survival was much better for those, which is the blue line, for those who underwent high volume plasma exchange. They observed these patients for 3 months. So this is the time of observation. We don't know whether these good results would be still observed later, but the paper is really very interesting, and we referred to this paper in our guidance. So at the end, I would like to share with you another case, a 14-year-old girl admitted to our hospital with a normal AAT, normal albumin, with splenomegaly on ultrasound. So splenomegaly indicates chronic liver disease, with highly increased bilirubin. It's in milligrams per deciliter, so 16 milligrams per deciliter. It's really a lot. With low ceruloplasmin, increased INR, gamma GT, immunoglobulin, with low hemoglobin. So apparently with liver failure, low platelets. And there was high urinary copper excretion from the previous hospital, 720 micrograms per 24 hours. So it indicated really Wilson disease. So would you suspect Wilson disease, or you think it's another disease, autoimmune hepatitis, toxic injury? I know I cannot speak with you. That's a problem with webinars, that I do not have direct contact, but think it over, and here are the results and our decisions. So there was a severe clinical conditions with problems with consciousness. Wilson disease was suspected. We started D-penicillamine, of course, as in the guidelines. We started plasmapheresis, which means a high volume plasma exchange. So we use all these methods. We listed this child for liver transplantation because the prognostic score was 12, increasing even to 14. MELD was 30, increasing to 31. By the way, we also give a MELD score or PELD score depending on age. So the This was the treatment, and finally the child received liver transplantation. 6 days after listing was transplanted, and later on molecular testing confirmed pathogenic variants on both alleles. So this is HQ with this typical mutation for Poland. So that's the typical case. It's not unusual, but I would like to share with you this typical, not difficult experience. We had more challenging cases. So just at the end, a few comments about low copper diet. Almost no evidence to use it. This is our recommendation, that perhaps those food products with very high copper content should be avoided, at least during the first year of treatment, but there's no evidence at all for that. For pregnancy and breastfeeding, we recommended maintaining anti-copper therapy during pregnancy and breastfeeding. So the danger for pregnant women is really stopping therapy, and it's also the danger for the baby. Finally, there were many pregnancies reported on D-penicillamine without any inborn errors of the babies, malformations of the babies. So we still think that even D-pen can be safely given to pregnant women. And for breastfeeding, we recommend it to continue. For breastfeeding, we do not have much data, but there's some data that there is no substantial transfer of D-pen and triantine into breast milk. So still we regard these drugs are relatively safe. The final question which is asked, and which we did not discuss much in the guidance, but I would like to share it with you, is the newborn screening. We discussed it recently in Aarhus, and there's a method. Why it is discussed? Because there's a good method for screening from dried blood spots taken at birth from the babies. ATP7B peptide can be measured. So peptide concentration can be measured. And this peptide concentration seems to be very specific, very sensitive for Wilson disease. There's also a nice study published recently from US, where DBS samples were taken in a pilot study from 30,000 newborns, and two cases were finally diagnosed to have Wilson disease. Positive predictive value was only 25%, but still negative predictive value was 96%. So it looks like a very sensitive test, but still it will need confirmation. And perhaps in 1 of 4, according to this study, in 1 of 4 we finally confirm Wilson disease. Still, even this is a good way perhaps to proceed. So this is our proposal from what we discussed in Aarhus 2 weeks ago, that if we have this positive DBS test, it should be repeated. Finally, sequencing, so genetic testing, should be performed together with biochemical assessment, and we should follow these babies. When to start treatment is a major challenge, because usually they will not have any symptoms at the age of 1, 2, even 3 or 4 years. So when to start therapy, it's a big question for a big debate which we had in Aarhus, without a good solution, without a good answer. So drugs for young children. If we want to screen, we need drugs for young children. We do not have formulations for young children. So swallowing is a problem. In the dosing is a problem. So our practice, and this is what I share from our publication, our practice was, of course, to crush to the tablets and to give zinc with water. Depends. Sometimes we administer with juices. It was efficacious treatment, but of course not according to any rules or regulations, because these tablets were not registered for such small children. Future therapies, I will not go into details, because in fact gene therapy perhaps is a future, but nowadays the trials raise more questions than solutions. 2 trials in adults were started, one was stopped, one still continues, as I know. There are other gene therapies, genome editing, nucleic acid therapies, but still not in clinical trials in mouse preclinical models. Methanobactin, other chelators are being studied again in animal models and preclinical studies. And Alexion, new molecules, was studied in a clinical trial which was stopped, but being re-evaluated. I was involved in this trial. So there is not much new concerning new therapies, but the old therapies are still very effective. So for take-home message, I think I would say that we should first of all think about Wilson as the disease which can cause any liver problems in children above 1 year of age. Also neurological signs, but very rare in children, could raise this suspicion. We should interpret copper tests in context, of course, of the disease, and molecular testing should be involved nowadays. It's really obligatory. And we should start treatment promptly, quickly, because disease may progress quickly, and we should not wait too long with the decision. So quick diagnosis is also very important. So Wilson disease with the drugs we have is treatable if recognized early and managed systematically. So ChatGPT helped me with this cartoon. My cartoons were very simple, but this one is more complicated, perhaps too much, but I like also to play with ChatGPT. So I hope this cartoon still gives a good message to you. Thank you very much for your attention.
Thank you very much, Professor Socha. So now if anyone has questions, you can write the questions into the question box. We already have 2 questions here. So I can read it out. So the question is, first, thank you for the excellent and informative webinar. The question is, a 2-year-old child diagnosed genetically with Wilson's disease, ceruloplasmin levels are markedly low. Relative exchangeable copper cannot be measured and the Fornesi score is 6. The patient has recurrent transaminase elevations without cholestasis. In such a patient, what should be the main therapeutic target during chelation therapy? Is lifelong chelation always recommended, or can treatment interruption or de-escalation be considered after a certain period if liver enzymes normalize and the clinical course remains stable?
So first of all, if I remember, the diagnosis is confirmed, because genetic testing was performed. So
yeah,
it's confirmed. The major presentation is increased ALT, about 200. So it's a significant increase. Still, even with this increase, if there's no hepatomegaly and splenomegaly, we can consider zinc as the first therapy. We can consider that, or we can consider chelators. In our practice and what we publish, with very high increase of ALT, we usually start deepening insulin. But I would say, even starting with zinc, if there are no other abnormalities except ALT 200, is acceptable. If you start with chelators, as I understand from the description, chelators were started. So after normalization of ALT, because what we want to achieve with therapy is to normalize ALT. With normalization of ALT, we can consider to switch to zinc. We usually do that. Or we can lower DPEN and continue on DPEN. It's also acceptable. But in our practice, we usually change to zinc. Still, of course, if you change to zinc, you may have problems with abdominal pain and poor tolerance. So sometimes children better tolerate DPEN than zinc, and you have to be aware of that.
Okay, so the second...
It answers all the questions.
Yeah, the second question. Adolescent patient with suspected Wilson's disease. These patients have normal liver enzymes and liver synthetic function, no cholestasis, but mild isolated hyperbilirubinemia resembling a Gilbert phenotype. Ceruloplasmin levels are mildly low, 24-hour urinary copper expression is normal, and there are heterozygous for an ATP7B mutation. There is no other organ involvement, no hemolysis, and the Ferenczi score is 3. In these patients, would you consider starting zinc salts because of bilirubin elevation and possible copper metabolism abnormality, or would you interpret this presentation more as a physiological adolescent low ceruloplasmin state rather than true Wilson's disease requiring treatment?
What was ceruloplasmin again? What was the value?
Ceruloplasmin levels mildly low.
but not the value. We do not.
No, we don't have a value.
Yeah. So, honestly speaking, Gilbert disease, it's about 10% of the population, is not the reason to exclude Wilson disease, first of all. So we have quite a group of patients with Wilson disease who have also Gilbert. And but of course, Gilbert syndrome does not present with any other liver abnormalities. So no increased ALT, AST, and so on. So if in this child only ceruloplasmin is slightly decreased, we do not have any other tests, copper metabolism test, indicating Wilson disease. So I would say that it's perhaps only Gilbert and a heterozygote of Wilson, but we don't treat heterozygotes. So I would not treat. But I would follow this patient. And if there are any abnormalities, any liver abnormalities, AT increases or whatever, I would still reconsider making diagnosis for Wilson. Of course, the question is how genetic testing was performed, whether only common mutations were tested or not, or all mutations. So that's another question, because sometimes we start from 1 or 6 most common mutations. So you can dig further. You can make whole gene sequencing and check all the exons and all the mutations. So that's also the way to proceed, to be sure that it is not a Wilsonian patients. But in general, it looks like a Gilbert.
Okay, thank you. We have another question. 8.5-year-old child is being evaluated for persistent hypertransaminasemia and has a 24-hour urinary copper excretion of 190 microgram per day. There are no signs of acute liver failure. While awaiting the results of genetic testing, should copper chelation therapy be initiated?
What is the clinical abnormality? Increased ALT only.
Increased
Sorry.
hypertransaminasemia and 24-hour copper excretion 190.
And we don't know what is ceruloplasmin.
No.
Okay, so I think perhaps ceruloplasmin is normal. For this value of urinary copper excretion, we give 2 points. So according to Leipzig score, of course,
So ceruloplasmin 0.21.
21, so border level. So in fact, we give only 2 points. And usually when waiting for the results, in such a situation, when only AT is increased, there are no other abnormalities. So we would start with zinc, because zinc is relatively safe. And waiting for the results, I would start with zinc. But of course, we have to confirm Wilson disease. At this stage, we cannot make a decision for long. For the moment, I will start with zinc, perform genetic testing. Perhaps if REC, and if this is not enough to make diagnosis or exclude, we can really consider liver biopsy and liver copper. Finally.
Okay, thank you. Another question. Would you consider combination therapy with dipenicillamine and zinc in a patient with Wilson disease who continues to have mildly elevated liver enzymes despite 1 year of treatment with the maximal dose of dipenicillamine, particularly when trientine is unavailable?
So in general, we avoid this combination of giving chelator and zinc. First of all, you have to keep time between the doses here, because there's an interaction between these drugs. That's one thing. And we, even in the guidance, we stated that it's better to focus on one drug given properly. You cannot, even if you measure urinary copper excretion will behave differently on zinc, differently on chelator. So that's why if you combine these two drugs, you don't know what to expect from urinary copper excretion. So I would rather focus on one drug. I would check adherence, because non-adherence is a major reason for poor effect. And if you cannot give trientine, because I understand that there is not such an option, because you can easily switch from D-pen to trientine and check whether trientine would be more efficacious, and we do it sometimes. If this is not the case, I would rather focus really on adherence. I believe this is the major problem. Whether to switch to zinc from D-pen, no, we don't expect that zinc will be more efficacious, but If there are no other symptoms except for increased transaminases, still I would consider changing to zinc. It's also one option. But I think rather administration of DPEN is the problem.
Okay, so how much time would you wait with mildly elevated ALT before you start thinking about changing therapy? Or yeah.
Under DPEN, we expect normalization of ALT a little bit quicker, but quicker means half a year, 4, 5, 6 months. So it's not really very quick. On zinc, even 1 year. So really long term. So I would discourage you from making quick decisions. Rather be patient. Of course, if you have increasing ALT or some other abnormalities, that's a different situation. But be patient when waiting for normalization of ALT, or even sometimes it's in many cohorts. Many experts say that they do not have full normalization. Like our colleagues from adult neurology and hepatology, they say it goes down up to 1.5 upper normal limits to this level, and not to completely normal levels. But still, it's okay if it goes almost to normal levels.
Okay, thank you very much. Now the last question. 10-year-old child with Wilson's disease presenting with acute liver failure. Do you consider chelation with penicillamine or trientine or zinc or plasmapheresis awaiting liver transplant? So what
I would do, a child is with acute liver failure,
acute liver
on a
failure,
waiting list. And if we suspect Wilson disease, I would give DPEN, high volume plasma exchange, so both treatments, all together. Always, and we discuss also whether we make a mistake if we cannot confirm finally whether it's Wilson, but we give DPEN. It seems that it's better really to make this mistake and to give DPEN, because some patients may improve, than not to give it and finally lose this change to treat a child with Wilson disease. So we start DPEN if there is a significant suspicion of Wilson disease. Of course, not confirmed, because you cannot confirm quickly, but high suspicion.
Okay. Thank you very much, Professor Socha, for all the answers, and thank you for all the attendees to attend today's webinar. And I'm welcoming you already today to our next webinar in June. And thank you very much for everyone to attending.
Thank you very much.
Bye.